All right. Good afternoon, everybody. Hopefully everyone can hear me all right and can see the slide that's on the screen. And this afternoon, we're going to be talking about opioids and HIV. And I'm going to talk really quickly about two things. First is this slide, which is an example of work that Taiwan did many years ago now. But it really is an example of effective combination HIV prevention and harm reduction. And what we're going to talk today about opioids and HIV, there's a strong dose of harm reduction involved. So there are a bunch of curves here. You can see the red and the blue squiggly lines there are criminal arrests. Red is heroin, blue is methamphetamines and stimulants, also marijuana, kind of anything but opioids. And you see the pinkish line at the bottom is rising HIV rates. And in between 2005 and 2006, they had this increasing number of people who were who were using drugs and who were getting HIV. And the pink line is particularly new HIV cases among people who inject drugs. And the Taiwanese government jumped on a really large program. And that large program included both methadone maintenance and broad scale syringe access for individuals. And what you can see is that although people continue to use drugs, that's the green and the blue, and people continue to inject drugs, the number of HIV cases went down. So it's kind of a lesson and an important discussion point. Number one is sometimes you may not get the outcome you want, which may be heroin cessation, but you actually are getting some really great secondary gain, which is decreasing HIV rates among a population. The second thing is just to remind us all, and of course, everybody on the front lines of HIV work knows this quite well, and that is that the work that you're doing is of paramount importance to the people that you care for. And so my former section chief told me the story once, and when he was a medical student at Columbia, and he was taking care of a former heroin addict who had pneumonia, was hospitalized. And he's a dutiful medical student. He's going to do the history and social history and all this stuff. So he's doing the social history. He's talking to this guy. And he says, "So, sir, what do you do for a living?" The guy says, "Well, I play the trumpet." I say, no. Like, how do you make money? Like, nobody makes money playing the trumpet. Like, how do you really make money? "Oh, yeah, I play the trumpet." It's like, former heroin addict? Like, I mean, how does this guy, I don't know. So he's like, "Okay, fine, Mr. Davis, whatever, The guy's like, "No, when you come back, when I get better from pneumonia, I'll play the trumpet for you." So the person he was speaking about was Miles Davis, and Miles Davis knows how to play the trumpet and made a whole lot of money playing the trumpet. But my section chief, who didn't know anything about people, he knew a lot about ticks and Lyme disease, totally missed the fact that you could actually be a former heroin addict and be creative, successful, and contribute very meaningfully to society. And so I tell that story as just a great reminder that you never know that the person you're taking care of, I mean, they may or may not be the next Miles Davis, but certainly has something meaningful to contribute to society. Just as a reminder, you can put things in the chat. You can, just unmute yourself and speak up if you like, if you have questions. This is meant to be a dialogue and a conversation about things that are practical and important in the work that you're doing. And this isn't even necessarily meant for me to be answering all the questions. We're a community here. A lot of people have great experience. So let's listen to one another. So who wants to kick it off? Or I can tell more anecdotes, not so much with Miles Davis, but with other colorful characters. We're going to talk about urine toxicology. I got a lot of people in trouble once in a methadone program who all were opiate positive, and they had told the counselors at the methadone program that that's okay. They're on OxyContin. That's why they're opiate positive. The problem with that is oxycodone is an opioid and not an opiate. So I had to break the news to the program that the patients were all selling the oxycodone, buying heroin, which is much cheaper. and were both getting high and profiting from their pain meds. A lot of people lost their take-home bottles. I was not invited back to that program. So most important thing in urine toxicology is to know what your assay does. There are two kinds of assays: immunoassays, which are the dipstick kind. They get fooled pretty easily, depending on what drug you're looking for. Some are more difficult than others to fool. And then the gold standard, which is gas chromatography, mass spectroscopy, a lot more expensive. In our system, we only use GC mass spec as confirmation, just because there are consequences to revoking bottles, or as we work with criminal justice, to people violating parole or probation. So methadone, oxycodone, and fentanyl are opioids. They do not show up as opiate positive unless you eat a whole lot of the oxycodone. Buprenorphine is an opioid, does not light up as an opioid. Immunoassays can get fooled. Ciprofloxacin is a kind of a classic one, but you should always talk to the manufacturer. We had a rash once of a bunch of people on generic sertraline who wound up showing up benzodiazepine positive. We sent things off for GC mass spec, and they were all wound up being negative. It was all the Zoloft. So someone was asking about what lights up as an opioid again. So the way to think about it is there are opiates, which are derived from the poppy plant. So that's going to be morphine, opium, heroin. They're all going to light up as codeine. They all show up as an opiate. If it's made by humans, it's not going to show up as an opiate. It's going to show up as the drug that you want. So if you want to find out if someone's on methadone, you have to get a methadone assay. If you want fentanyl, you got to check fentanyl. If you want oxycodone, you need to do an oxycodone assay. If you want to get fancy, you can do a 6-acetylmorphine assay, which is the heroin is diacetylmorphine. It becomes 6-acetylmorphine, and it becomes morphine. That lets you know if the opiates was heroin derived or not. You can spend hours and much fun looking at urine toxicology results. Maybe not as much fun, but you could spend hours doing it, certainly. I think the real question is, what do you do with that information? And I think the most important thing is not being punitive necessarily, but from my perspective, we kind of use urine tox as the 5th vital sign. And so everybody gets one, and it's just a conversation point, right? And the most important thing is you don't always divulge your knowledge, right? So I usually start off a conversation with a piece of paper in hand, and I'll look at it and I'll say, is there something that you need to tell me? Now, because the patient doesn't know what's on my piece of paper, I've had all kinds of people tell me things that weren't on the piece of paper. So sometimes bluffing is really helpful. But again, the information really begins a dialogue. So if you're smoking crack and you're not taking your buprenorphine may not be the right level of care. Or if you're using heroin and not taking your buprenorphine. So it's about a conversation piece, but it's not a single data point that drives all of our actions. So someone's asking, anyone with any success in prescribing buprenorphine in the Ryan White Clinic arena? I have an MAT waiver, but getting a lot of pushback. Yeah, so I think, I'm a biased consumer here, I think everybody should have an X waiver and everybody should be prescribing buprenorphine. And the reason is because methadone clinics are hard to come by in many jurisdictions. They're just impossible. In the HIV outbreak in Scott County, Indiana, there weren't methadone clinics in the area. The only option for treatment wound up being buprenorphine. And even that was hard to come by because there were many people in the area that didn't have X waivers. So absolutely, Ryan White clinics are the perfect place to get an X waiver, to be prescribing buprenorphine. And buprenorphine treatment, and we'll talk a lot about this on Wednesday in the plenary, it's much easier than Hep C treatment or HIV care. If you're providing HIV care in an evidence-based fashion, you're doing something more difficult than prescribing buprenorphine.
Greg, we at UK, and I think you've helped us, haven't you, Doug? I'm getting mixed up on what way you've helped University of Kentucky, if it was with the AIDS United grant or if it was with the Wiseman Center. But there's a lot of stuff out there for you. It's not easy. People don't want you to do it, but your patients will really appreciate it. And it's, you know, it's challenging. I have had lots of support. I still feel like I'm just a baby prescriber. And I have a really great pharmacist right now, and we have some really good people, Laura Fanucchi, and our nurse practitioner. She actually is the lead right now. So it can be done. You just have to be very patient with yourself. There's a lot of good stuff out there, and to help you start that.
Absolutely, and we encourage people just to start out slow and easy.
Yeah.
And so, some patients are going to do really poorly, and some are going to be rock stars. I mean, I was telling people in the methamphetamine discussion yesterday, I had a patient who was a heroin user who showed up at the HIV clinic one day. That was a Friday morning. I wasn't even supposed to be in clinic. I was catching up on my charting, something that I'm sure no one here is familiar with. And this guy shows up. I got out of jail. I got to get on buprenorphine. I got to get this thing. I'm going to relapse. I'm going to go back to jail. He knew generations of correctional officers. I mean, he was like famous as just the untreatable person. And we started him on buprenorphine. Guy did great. We used a little bit of contingency management, cognitive behavioral therapy stuff we'll talk about on Wednesday. And he wound up finishing probation. He had never done that before in his life. He had a case with DCF and some domestic violence issues. I mean, he became the poster boy of like perfect citizen to the point that like he didn't need me anymore. He transferred care to another provider, and I actually had other people in the community who knew him and thought of him as a lost cause, who started coming to me saying, hey, like, what's Keith on? Because like he's sober, and no one ever thought he could be sober. Give me what he's got. And he actually became a bigger ad for getting people sober with buprenorphine in the early days than me walking around the neighborhood. You know, guy in a blue shirt and khakis with a Yale badge doesn't do well for advertising in some neighborhoods. So there are actually a lot of, someone mentioned that Dr. Dan Moore in Arkansas has been able to integrate MAT into Ryan White clinics. So there's been a lot of work on integrating HIV care into and buprenorphine care together. It goes way back to a thing called the Beehive study. And Laura Cheever, who's on the call, has been a big proponent of incorporating buprenorphine treatment into HIV clinical settings. And it's something that HRSA supports very strongly. One of the questions was, how do you manage patients on both buprenorphine and benzodiazepines? So I'll tell you my disclaimer, which is that benzodiazepines scare me more than heroin. We have a lot of benzodiazepine use in the New England area. It's become the substitute for alcohol for people who are using stimulants and want to come down from the side effects of smoking lots of crack. So we have patients who are eating, 6-8 milligrams of Xanax a day, which is over 100 milligram equivalents of Valium. So this is a lot of stuff. And it takes about a year taper to get people off of that amount of Xanax or Klonopin. It's very difficult to get people off of the benzodiazepines. They will have withdrawal symptoms that they see as a panic attack. They go to the emergency room, they get more benzos. It's this horrible cycle. One of the big problems we have with it is the data that shows that benzodiazepine use can cause dementia over long periods of time. And also because it causes enterograde amnesia, and you don't develop tolerance to that. That means that from the time you take it forward, you don't remember. So if the patient takes a Xanax and comes in to see you, they'll remember seeing you, but any important stuff that you've tried to communicate, they're not going to remember. And that's really problematic if you want to change meds, if you want to, I mean, I'm sure you probably had the experience of, wait, we talked about this last time, and the patient's like, no, we never talked about it. You talked about it. They just can't remember. And then the thing that you do when you use benzos chronically is people confabulate. They will just kind of make up things to fill the time caps. So in our world, we get people off benzos and we will try and work with them. We'll connect them to mental health services. We'll work with long-term tapers. As long as someone is willing to work with us, we'll get them off the Xanax, get them on Klonopin. We'll work with psychiatry. We'll do a year-long taper and get them off. As people are working with us, we're happy for them to be on the buprenorphine. The overdose, it's not so much an overdose risk, which was an earlier concern. It's more if I impair your memory and I want to teach you a new way to cope, to live without drugs, I can't teach you anything if you can't remember what I'm teaching you. A couple people in the chat are talking about their experience with Suboxone Care. And those with success, any experience doing Tele buprenorphine care, absolutely. In the COVID world, all of Connecticut Medicaid basically went telehealth. And so we have been doing telehealth with buprenorphine patients. Patients go to a Quest lab or another lab and will submit a urine toxicology. We have been having certainly new starts, and people who are just starting out treatment actually have to come into the facility. And we follow a COVID procedure to do that. But people who have been doing really well, we can do things via telehealth, unless we start getting concerned or suspicious or something weird's going on, in which case we bring people in. So regulations for telehealth have been loosened, but will this continue when COVID is over? That is a great question. Medicaid, although a federal program, is administered by states, and so it will be dependent. In Connecticut, we're operating under an executive order that takes us to September 14th. There's conversation that it will continue, but in theory, telehealth ends on the 14th for Medicaid payments, but we're pretty sure it will continue. I think for a lot of our patients, we've actually remarkably, right, so just as an aside, we've been able to connect with more people more frequently and had almost better success. Coming into a clinic physically can be a high barrier for many of our patients to do. But I mean, I got a lot of drug users that we take care of who have smartphones, and they'll call in, or they can do a FaceTime or a DoxyMe. So we're all hoping that it continues, because it's certainly been incredibly beneficial. Another question is, are you doing more home inductions than in-person inductions for buprenorphine? We do a combination of both. A lot of it really depends on the patient, how familiar they are with them. We take care of a fair number of decisionally impaired people with severe mental illness, paranoid schizophrenics and other individuals. So people who are impaired, we're bringing them in, we're walking them through it. And the main concern that we have is people will take it too early. This is something that we've heard from people buying buprenorphine illicitly on the street. People will come into the clinic and say, oh, I need a new methadone, I can't do buprenorphine. Why? Well, when I took it, I got nauseous and I threw up. Well, you pulled the thread a little bit more, and what they did is they took it while they were still on opioids, and they had precipitated withdrawal. So we'll do some home inductions, we do some in person. The home inductions, it used to be frowned upon. I don't see any problem with it. The big thing you want to make sure is that the person's actually taking it, right? So you're going to want that person to do a urine toxicology or touch in at some point, and you'd want to make sure that you screen for buprenorphine, just to make sure that the person actually did do the home induction. Are there resources to train RNs, LPNs on MAT? Absolutely. There are lots of resources that are available. So the state of Massachusetts has a really large buprenorphine program, and it's a large nursing-based program. Yale also has a program on that. It's really most of what gets done, and even in our environment, it's a lot of nursing visits. Nurses are able to take the time, the physicians or nurse practitioners or PAs are involved in actually the induction process, dosing, and figuring out how much to prescribe. But a lot of the care is done by RNs throughout the course of the patient's treatment. And then on the behavioral health side by licensed clinical social workers. So there are actually a bunch, and what you can do, email me at robert.bruce@yale.edu, and I can connect you to some other resources. So someone's asking, can you review inductions? I've been getting different instructions on how difficult the inductions are and how much support you need for an induction. We've been sending to the county hospital for induction because it's perceived that you need a lot of support for an induction to happen in the clinic. So first I want to encourage, inductions are not that hard. Unfortunately, early on, I think there was a lot of concern and fear about people being in opioid withdrawal and waiting rooms, and kind of that would become disastrous. In reality, patients actually are good kind of barometers for when they're going to get into withdrawal. So we tell patients, look, you need to be in mild to moderate withdrawal. Well, what does that mean? Well, you're starting to feel the body aches, you're starting to feel a little nauseous, you've kind of got some sweats, you feel like you need a cop for a bag of dope. But instead of doing that, you're going to use Suboxone. One of the most important things for Suboxone induction is actually teaching the patient how to administer the medication. So the reason Suboxone is, and all buprenorphine sublingual products are sublingual, is that they have to bypass the liver. So first pass hepatic metabolism of buprenorphine is 90%. Right? So 90% of the drug is destroyed once it hits the liver. So if you swallow the pill, and the pill is absorbed, goes into the portal hepatic system, goes to your liver, you've lost 90% of the drug. And one of the big problems that we have with patients is that, I mean, nobody wants to have something under their tongue and they want to let it dissolve, right? I mean, the number of patients I have that will come in and say, yeah, I take it, fine, show me. Oh, they got it under their tongue, they're drinking coffee, they're sucking on it. They're like, we're done. That was like 30 seconds. Oh, no, that had to take 5 minutes. No, like, we haven't been in the room for 5 minutes. Like, it can't be 5 minutes. So one of the most important things, and what I tell patients is, look, the longer it's in your mouth, the longer you don't swallow, all that happens is you're dissolving this film. Once it's dissolved, then it's got to go get absorbed. Once it gets absorbed, then it goes to your brain. And I just tell patients, you get more bang for your buck. The longer you hold it in the mouth and don't swallow, the more it gets absorbed, the better you feel. This is also important in dose adjustment. So if when somebody comes back a month later and they're like, I was fine, but I'm not fine anymore. Man, you know, my cousin takes 24, I'm only on 12. Why don't you double my dose? So one is, well, I don't, you know, why do you need 24 now? Just because your cousin's got 24 doesn't mean you need 24, right? So we review the whole dosing. Are you having symptoms? What's really going on? The other thing to be very concerned about is diversion, right? If you've been fine on a dose. For buprenorphine and methadone, you typically don't need a dose adjustment unless there's some kind of big life issue, you got pregnant or something big happened. Can you comment on saliva drug screens? Saliva drug screens are another good way in order to get data on what people have been doing. We tend to do the urine tox because we can send the person to the tox lab. It's covered by Medicaid. The big thing on the saliva test is just to make sure, in cooperation with the toxicology people at your lab, and you should have access to any of those people. So for example, Quest has actual toxicology people. So when I wanted to find out more information about, hey, I got this urine toxin, I don't know, like, I don't understand what this means, and could this drug be affecting it? You can reach out to those people and say, well, look, you know, when we had that sertraline causing a benzodiazepine thing, I can reach out to the Quest folks and say, this is what I'm getting, what's going on. We sent it off for GC-MS spec, it came back negative. I'm thinking it's a false positive, and they can say, oh yeah, you know. And eventually they actually had to change their assay, and then that went away. There are a lot of other assays, right? So hair is as long as you have had hair, right? So if you got really long hair, it's a drug screen for as long as you've got that long hair. If you got short hair, it's obviously a shorter screen. There are sweat tests as well. Urine's just most frequently the one that's used. So one of the questions is that whether buprenorphine can be used for acute short-term pain. So yeah, absolutely. Buprenorphine was originally an analgesic for patients who are on buprenorphine treatment. Or people who are opioid dependent, they don't tend to find buprenorphine to be a really great analgesic. People who have chronic pain will sometimes be on higher doses of buprenorphine than the normal kind of maintenance treatment dosing. Like with methadone, and for reasons we don't understand this, the analgesia of a drug tends to be more with peaks. The maintenance for like heroin dependence is more with the trough. So for methadone, you go once a day. We're not worried about the peak except for side effects, but it's how low you go, right? So the same for buprenorphine. For pain though, it's the peak, right? So it's really, you have to wind up having multiple peaks in order to get analgesia. So if you have a patient who has chronic pain, you've got them off a bunch of OxyContin, and you know, maybe they started doing heroin, and they're coming to you saying, yeah, you know, my back hurts and I'm taking the Suboxone once a day or even twice a day. Breaking it up to 3 times a day can be more helpful in combination with an NSAID or other non-opioid treatments. How do you handle a patient on Suboxone going in for elective surgical procedures, for example, a knee replacement? So we first make sure that the surgeons are aware of what's going on. Some surgeons or anesthesiologists will have particular methods in which they want to address this. we typically advise the patient to stop the buprenorphine the day before. Like if they're going in the next morning for elective surgery, so today's Monday, you're going in tomorrow morning, I'd say, don't take your Suboxone today. It's going to be wearing off. Tomorrow you're going to go in. They're going to give you opioids. You're going to get your treatment. You're going to get opioids post-surgery. And then at some point, the surgeon is going to give you a limited supply. And surgeons have been getting lectured to ad nauseum about the number of days to give opioids. So what ends up happening is people, a lot of our patients will come back and be like, I got 8 days worth of opioids. My knee's killing me. Like, I'm really coughing you. I need you to get me back on the Suboxone. So we'll move people back when the opioids are done. Again, this is before surgery, a release of information with the surgeons. We'll support the surgeons pre and post-op. Some surgeons will actually, and anesthesiologists will prefer that people are taking Suboxone the day before and just don't take the morning of. The reason that it's important for them to be on board is simply because of receptor occupancy. Buprenorphine can occupy upwards of 75 to 95% of receptors. So what ends up happening is it's a blockade, right? So now the surgeons are using more fentanyl and other things. So again, it's a dialogue between you as a prescriber and the surgeons. This was a bigger deal 15 years ago. I'll tell you, most hospitals and most folks have a sense of what to do these days. Can you talk about Sublocade, and should we transition patients from the PO to the injectable? What are the pros and cons? So I think Sublocade is a great thing. We actually have not been able to get it in Connecticut. It's a little tricky for Medicaid and our approvals as well, because it's more expensive than the film. And because we can't get it through a normal pharmacy, it's got to be shipped to us directly. So that was a little complicated for us as an QHC. So the big thing to really think about is one of adherence. So the pro-con issue is, the patient's got the medication in the patient's body. You're not worried about adherence. You're not worried about diversion. It's there. The con is only really around other kinds of interventions you need the patient to do, right? So what we use the films for often is contingency management. So if I need you to see a therapist, so again, I deal with a biased population. All of our patients have severe mental illness. We have a lot of patients who are victims of sexual or physical violence. And so they need to go to therapy, and we want to support and connect them to therapy. So we'll give people, enough of the buprenorphine to get to that next therapy appointment, right? So you're coming here next week anyway, you're going to see your therapist. I'll give you a week's worth of buprenorphine. And so as the patient does better and that gets paced out, and then you're giving them monthlies, that would be a person I would transition to Sublocade. Again, there may be patients who don't have the trauma, severe mental illness that our patients do, and could be on Sublocade earlier. Can you comment on jail and prison system having challenges continuing meds while incarcerated and getting meds upon release? Absolutely. So Rebecca Schleifer and I wrote, she was with Human Rights Watch. We wrote a paper, which was a human rights and ethical argument on why all correctional systems should be required to have buprenorphine or methadone. And the reason is because, the way the law works is people who are in jail or prison, while their liberty is restrained due to being incarcerated, their access to healthcare should be equitable based on what's available in the community, right? So, we could make the argument, we now have buprenorphine and methadone in our jail, but we could previously make the argument of there is methadone and buprenorphine all around the jail in the community. It is actually not okay that, and I had a patient with HIV, this is in the days when people took those gel caps for Kaletra. He was on methadone, 100 milligrams, doing great. He got incarcerated as a violation of probation. It was some stupid technicality. He goes to jail, they don't give him methadone. He goes into withdrawal, trying to take his Kaletra, gets volume depleted, gets AKI, and he gets sent to the hospital, all because the jail didn't want to give him methadone. So I would say look up the paper. It's an argument for why people should do it. If you're super socially minded and want to contact the LCU in your area, you could do that as well. Every correctional system should do it from moral and legal grounds. People don't like to do it. One of the arguments that correctional systems use to avoid doing it is they will say, I don't have anyone to connect the patient to upon discharge. This was Connecticut's argument. I can't connect them to anybody, so I can't start them because it's not fair. Really, they were concerned about their liability. They started the guy, he couldn't get any treatment. So we had to say, well, look, and we said to the Department of Corrections, we'll continue buprenorphine for anybody that you discharge, anybody, right? So now it's on them. Send them to me, give me their name, I'll call the guy, like we'll connect them. So what I would say is work with the folks. It's especially particularly important for our patients with HIV who are incarcerated. If they are connected to buprenorphine when they get out, they are much more likely to come in and continue their HIV care, right? You've just gotten in prison, and to be honest, the greatest risk of overdose and death is 2 weeks post-discharge from jail for an opioid user, because their tolerance is gone, they come out, and what's the first thing you do when you leave jail? It is not go read War and Peace, right? The first thing you do when you get out of jail is, I'm gonna go get high, I'm gonna go do this, right? I've been thinking about while I'm in jail, all these things that I'm gonna do, and I go do it. And what ends up happening is what? Well, I did 10 bags of dope when I got locked up. I'll do 10 bags of dope today. My tolerance is gone. You know, half of what I'm using now is fentanyl, and people OD and die. So it's also critically important that people are started on buprenorphine or methadone prior to discharge in order to continue them and reduce their risk. There is data, Sandy Springer's done work looking at naltrexone, naltrexone, or Vivitrol upon release from incarceration. And that actually works really well. Vivitrol is very, very difficult to do for people actively using in your HIV clinics because you have to be off heroin for a week. And so, you know, for all of my patients, if they could stop doing heroin for a week, they don't need anything to find, right? I mean, like, who can stop for a week? So, but in a correctional environment where you have been unable to use, you've gone through detox, getting a shot of Vivitrol also is very helpful to prevent overdose, linkage to care. Patients like buprenorphine or methadone more, they're agonists, but patients can do well on naltrexone. Can you talk a bit about buprenorphine dose in a patient who's getting Hep C treatment? We don't worry about drug interactions or dose modifications. I did some of the PK work on declatosphere and some of the other drugs, and it's really not something that we're overly concerned about. Again, one of the things to think about there is contingency management. So if the patient was really chaotic and struggling, homeless, there are other things, we might say, well, you know, come in weekly, we'll get you a week's worth of bup, we'll get you a week's worth of the Hep C treatment, and we'll check in on you. One of the things that's super important, because all of our substance users have really loud voices of judgment in their minds. The whole time they're using drugs, the voice they hear is, you're not good enough, you're a bad person, everything you do is inadequate. It's just constant negativity. Never underestimate the amazing power of them hearing something positive from you, right? I've got patients who, I would, you know, I try to make them laugh. We would do goofy things, you know. One year I went through the methadone clinic lobby with red and green condoms. I was like, it's Christmas, everybody, you know. And they thought, this doctor is crazy. Like, this guy's a nut. But everyone laughed, like, oh, you know, maybe this place isn't as depressing as it has to be. I'm not saying you should run around town throwing red and green condoms around, right? But the point was, and what I would always tell the providers we were training, if coming to see you is miserable, no one wants to come see you. So, you know, if you're just a miserable person, okay, fine. If you've got drugs, if you've got buprenorphine, patients will come even if you're a miserable person. But if you can do anything to make it slightly more interesting or positive, you know, saying to the patient, hey man, that's so awesome. You know, okay, you're drinking half as much as you did. You're smoking half as much, or hey, you know, you went out and did some work today. Finding the little things. I mean, I would tell people like, hey, you know, I like your shoes. Hey, is that a new shirt? That's really cool. And it was all about trying to build a positive attitude. Patients want to hear something positive. They're desperate for that, as we all are. We all want to be liked. We all want to hear something positive. Our patients are no different. And so one of the reasons we would have people come in weekly for Hep C treatment or other things, especially when we did Hep C treatment with PEG interferon with drug users years and years ago, we had to see everybody every week to give them a shot, but also we were making everybody depressed with PEG interferon, and we really needed to be positively encouraging people as much as possible. Do you have a recommendation for a professional resource for looking up when medications can cause false positives on urine drug screens? So I would say first to speak to the lab that you're sending drugs to. They should have something for you. Partly because, I mean, you can Google anything these days, but it's also really important to know, and the company will know, this is the assay that we're using, this is what we found. Otherwise, I would say shoot me an email. Let me see if I can find you something that would be an easier resource. For those who don't already use the Liverpool Drug Interaction website, that's a fantastic resource. For those of you, hopefully everyone looks at the DHHS guidelines for the adult and adolescent antiretroviral treatment. There is an updated section on substance use that has a bunch of stuff in it. The the IDSA, HHI, VMA guideline on chronic pain treatment in people with HIV. That has a section on urine toxicology. It's a free open source document. Go to the online one. The printed one was an executive summary, but the online document's like, very long. Get a big cup of coffee if you sit down. But it's divided into sections, and the urine tox one's really helpful and talks some about that. Jay at IAS-USA is reminding of those to, if you haven't already, feel free to shout out, comment on what we've talked about, raise a new question, tell us a humorous anecdote.
I don't know if mine came through. We recently had a young lady in the hospital with endocarditis who has a prosthetic valve, and it was MRSA. So of course she was on rifampin, and she was taking her Suboxone, and she really seemed to exhibit symptoms of withdrawal. Have you seen that with rifampin and Suboxone?
Absolutely. Rifampin is the most powerful inducer. So in a patient like that, you pretty much have to double the dose for it to work. It does that in methadone and in buprenorphine. In fact, rifampin is really the only thing that causes precipitated withdrawal in patients on buprenorphine.
So if you have to double the dose and on discharge, how are you getting that approved through the insurance company if you're getting into doses above 16, 24, et cetera, because you're having to double it? Are you having good success with prior approvals, or is that a challenge?
So I haven't had to do that with rifampin, but when we've had to do things like that, what we would do is we have a prior authorization for Medicaid, and you would just have to write in the justification there. For the most part, because the rifampin buprenorphine interaction is a published paper by Ellie McCants-Katz, there's data available, and you can just cite the paper, and then we tend to not have a problem in Connecticut, but I'll be honest, Connecticut's pretty liberal with letting us get people on treatment. We've been able to treat active substance users for Hep C treatment, active alcoholics, and I've been amazed. I mean, pretty much anybody who's willing to take the pills gets cleared. It's really amazing. Question here, any advice on managing alcohol and opioid use concurrently? Absolutely. So because alcohol and opioids both somehow actually wind up, there's this connection we think between the opioid receptor and Gaba. So the opioid receptor obviously is where opioids are going. Alcohol goes to Gaba A. And so we know that naltrexone, which is an opioid antagonist, so it parks in the mu-opioid receptor, it blocks it. I always tell patients it's like, normally you park your car in this way, it's parking the car this way, so nothing can get in. Somehow by blocking that, we think that it dampens whatever communication is happening at GABA A. So if people are drinking alcohol and you start them on naltrexone, they start drinking less. And the thought is that it's somehow negatively impacting the reward mechanism that happens when people drink alcohol. So one of the most important things is to try to determine what's the main driving factor, right? Is the alcohol use a bigger problem or the opioid use a bigger problem? And the reason that I say that is if you start someone on naltrexone, which is the best medication for alcohol use disorder, you can't do buprenorphine or methadone, right? So if the patient winds up with a situation where you could say, all right, look, you know, I can get you to stop the heroin for a little bit here. I can give you the Vivitrol shot. That's really going to help your alcohol. It'd be fantastic. Usually in our world, people are really just out of control with heroin. They're drinking some, then they come into treatment, they're on buprenorphine or methadone, and then we start to see this big alcohol problem. And so what we tend to try to do is then address the alcohol issue directly. You can do some medications. There's some data on topiramate. There's some data on gabapentin. Disulfiram is as good as placebo just because people don't take it because you know you're going to get sick. We tend to either push therapy with people who are using alcohol. Also, if you're on methadone, you can't get lots of take-home bottles. We'll do the same thing in buprenorphine. We'll say, well, look, you're actively drinking. This is a danger to yourself and others. So we want you to come in weekly. You'll meet with a therapist. And then depending on what happens, if people are really drinking, we might consider then transitioning them off of buprenorphine or methadone to the Vivitrol, because again, it's going to be much more effective in the treatment of alcohol use disorder. Alcohol is a big deal. You know, I think our patients don't think about it as a big deal, but when you think about the damage that it does, both from a neurobiological perspective and from a hepatic perspective, it's really devastating. I remember taking care of a 28-year-old in jail. He was HIV Hep C co-infected. He was already cirrhotic, and he was, you know, he'd been drinking a liter of vodka a day before he went to jail. I had to transfer him to a higher level of care in the prison system just because I was worried about him. I ask about insurance as we still have a few insurance companies that require rehab for Hep C therapy, and we write lots of letters and quote the current guidelines, and this is a barrier to care. So I guess one question would be, is that private insurance companies, or is that you know, Medicaid or Medicare? You know, for some insurance companies, their hope is that something happens and you lose their insurance, right? And so they don't have to pay for it. In Connecticut, at least, Medicaid has taken the long-term view of they'd rather pay now for to fix your liver, right, with Hep C treatment, you know, get rid of the Hep C, than to wait for all of the consequences of Hep C, which they realize will cost them a whole lot more money in the long term. So I would encourage you to continue to push the insurance companies. There's absolutely no data that suggests that you should have to do a rehab for any substance use prior to Hep C treatment. As I mentioned earlier, we have treated active alcoholics, we have treated the homeless, we have treated people with severe mental illness. The question really just simply becomes, from my perspective, what's the adherence support that I need to provide? The meds will work. It winds up, you know, do I need to send an outreach worker or somebody to go find someone on the street who's homeless? Do I need to have somebody come in every day? Should the methadone clinic be the place where you pick up your meds? What's the support that I have to create? I know the medicine works. I know that you have a drug problem. What do I need to do to help you? And I found open conversations with patients is really useful. I mean, you know, I had one patient who a prior provider had not been willing to treat him because he was actively using drugs. And he was using heroin predominantly. He was also in a methadone program, bad Lyme disease, all kinds of medical issues. He was older. And I was like, yeah, I'll treat your Hep C. He's like, oh, I'm not going to change. I'm going to keep doing drugs. You know, my big issue is the med won't work unless you take it every day at the same time every day. That's all I need you to do. So the interesting thing about this guy is that one request, he wanted Hep C treatment. I told him I would give it. I told him under the conditions under which I knew that it would work. And that was sufficient where he said, you know what, maybe I should stop doing drugs, at least just for the Hep C treatment. And he didn't tell me this. I only found out later because his therapist came to me and said, what did you do to this guy? And I was like, I mean, hopefully nothing bad. I was just treating his Hep C. She said, no, like he stopped drinking. He stopped doing heroin. He even stopped smoking cigarettes. He's like annoying now. Like he talks to me more. It's like, I can't help with the fact that he talks to you more, but you know, I didn't tell him to stop all the drugs. I told him he needed Hep C treatment. So all that to say, you know, if you have an open dialogue with the patients and really talk about, well, what are the things that you need to do to be successful? How can I help you be successful? I want to treat you. I want you to be successful. That I think is the key conversation point for patients. And patients, and I've done some weird things, right? Where I'm like, well, look, time your, if you do heroin in the first thing every morning, take your pill, the same thing every morning. And we would obviously try to target, Epclusa like a once a day drug versus multiple times a day. We do try to follow normal adherence rules and make things easier, but it works. So one of the questions, exploring other tools for harm reduction, how are folks managing their syringe service programs during COVID? Great question. I hope people are using secondary exchange. Other people want to comment on, or other people involved in syringe exchange programs that might want to comment on ways in which you're managing during COVID?
So we have some program income that's been used to put worker bees in the syringe exchange programs throughout Kentucky. And there was a lull initially, but one of the things I think you guys are gonna be glad to hear about this is when people started being released from prison because of COVID. Actually, those workers were able to help. And then gradually all the syringe exchange programs have picked back up. And over the last month or so, they had some outreach programs that they had backed off on, and now they've started working on those again. So we've tried to keep everything moving, but there was an initial sort of shutdown while people sort of regrouped and figured out how to do it differently.
That's great. Thanks, Alice. That's a great word on what's going on in Kentucky. Very encouraging. Others that want to share about syringe exchange? As we saw in that early slide at the beginning, right? Syringe exchange or clean syringes is one of the most powerful ways to reduce an HIV epidemic, certainly from a cost perspective and efficacy. As one of my old mentors, Jerry Friedland, would say, one of the reasons syringe exchange is so effective is that unlike condom use, a clean syringe does not negatively impact the experience. So it's really easy to persuade people to use a clean syringe. No one's using a dirty syringe because they think it's preferable. So great work. So Carol is saying our state will not allow us to treat Hep C if the person is actively using drugs. Very difficult to stop the epidemic. Carol, email me at robert.bruce@yale.edu and let's fight the state, because that I view that simply as discrimination. There's no data to suggest that that's necessary. So I would love to help you with that. So I live in New York. I'm grateful that New York State has worked hard to eliminate virtually all barriers for Hep C treatment. Absolutely, New York has been leading the front there to make sure that everyone has access to Hep C treatment. It's incredible work. And there are a few drug users in New York, so they've been doing great work. So definitely very exciting to see them. The AETC has template letters for Hep C and one for substance use. Thank you very much for sharing that link. Others, we have about 10 minutes left. And
could you speak a little bit about an induction with people that are on fentanyl? We've not had really great success, and our nurse practitioner, she gave it a whirl with some people, and she's feeling discouraged. And so any pearls?
Yeah, that's really hard. So are you speaking about the fentanyl, like the heroin that people are using that's adulterated with fentanyl? Or
Yeah. Well, I don't know. it almost seems like they were just using fentanyl. Like I said, I'm a baby prescriber. I'm just like gradually gotten into it. I think these people were doing it with heroin. You know, it was laced in their heroin, but I think they may have just been using fentanyl straight up.
Yeah, so some people are using, so there are lots of different things. There are a lot of the fentanyl patches have gotten away with the gel. They got rid of it. They did that because some people were cutting them open and eating the gel. There's all kinds of, I mean, there are fentanyl lollipops, there are all kinds of fentanyl products. A lot of the fentanyl that we get is actually coming from overseas. And obviously the reason drug dealers like fentanyl is because it's more compact, right? So it's, you know, a log more potent than heroin. So you can actually take and shrink down your carrying case. That the DEA, I was at the Yale Law School, and the DEA actually got a normal size briefcase, and it was something more potent than fentanyl. And the DEA basically said, look, there was enough stuff in this one briefcase to kill everyone in Connecticut 3 times over. And it was just because it was 100 times stronger than heroin. So you could pack it down. So what ends up happening in overdose often is that what happens is, you know, it's not always good for business to kill your consumer, right? Sometimes it is, sadly, but not normally. And so, but the guys mixing drugs on the street level they're not using metric scales, and they're, you know, you're buying cheap labor, you get poor output. And so what ends up happening is people are just, you know, kind of throwing stuff in baggies and selling it. And some people are tolerant, some people are not. Most of what's happening nowadays, there's going to be something fentanyl in it. Because of the global cocaine shortage, they're putting fentanyl in cocaine now. And people mix and match based on color, ultimately, because you're selling a white powder, you can't put pepper in it, right? It can't be brown or something else. So what ends up happening is you have all of these overdoses as a result. Tolerance is much more difficult with patients who are on fentanyl. And so what I would recommend in that situation is if the person has access to methadone maintenance, actually, because one of the advantages with methadone is you can start the person even if they're in mild withdrawal, even if they've recently used, because you're not going to precipitate withdrawal. So one of the things we've done with people with high tolerance is we'll say, we're going to do a short course of methadone, because people are like, I don't want to be on a methadone program, I hate methadone, blah, blah, blah. Look, you don't have to be on methadone forever, but we need to help you today. Let's get you stable. And then we basically take people up, park them, and then start bringing them down. And the whole plan is, okay, I'm going to then jump you over to buprenorphine. Sometimes patients get on the methadone, they're like, I feel great, don't mess with this, I want to stay where I am. Others are like, I'm really happy to make the jump. For the fentanyl folks, some of it then just becomes, if people are like, I don't want to do that, or if you don't have access to methadone, because that is a big problem in the country, then we really just have to say, okay, look, we need to find a way to support you. This is going to be hard. And so one of the ways that you can do that is the person's coming in, you give them more buprenorphine on that first day than you normally would. So you kind of say, like, I'm going to load you with a lot of stuff here, right? So I'm going to give you this 8 milligram film. I'm going to give you a couple more 8 milligram films today. I want you to take these today. You're not going to always be on that much, right? You always have to set that boundary in the beginning, right? You don't need that much. You just need that much right now because you're a hot mess. But we're gonna be giving you less. Excuse me. The other thing is really to have other kinds of supports, so you know that the person's not going to be sleeping well, so they may need trazodone. We've found that Vistaril, which is a sedating antihistamine, is helpful. We've given up to 100 milligrams every 6 hours, which would stop a freight train. I took 20 milligrams once when was in a cloud, right? So I don't know how anybody can take 300 to 400 milligrams, but we found that actually is very calming, helps people. It's not addictive, which is the other thing, and we want to avoid benzodiazepines or other things that could be habit forming. But a lot, and the whole subtext there is that it is very difficult. So the prescriber who's trying, I would encourage him or her and just say, look, you know, you're not failing as a provider because this is hard. This is just, objectively difficult. And so be encouraged, and I would be encouraged that he or she's.
I'm glad you said that, because she very much felt like a failure. And I'm like, look, you're trying to be helpful, and so this is great info to take back to her.
Great. So someone's saying that, unfortunately, Medicaid's denying F1 and F2 treatment in some people. We have had issues with that in Connecticut at times. Partly people look at that as a cost. Our argument has been, if you deny treatment to people who are actively spreading a virus, it will ultimately cost you a lot more. And that was New York's argument, right? Was like, look, we're going to pay for this at some point, so just treat them now, try and get ahead of this, and we're going to save taxpayer dollars ultimately. And I think that's the right argument. Someone's asking about the fentanyl test strips. So the rapid ones are immunoassays, so they're not perfect, but they can be very helpful. We give out test strips to people who are using drugs. The rationale for that is because patients need to know, like, look, if you're about to inject drugs and it's got fentanyl in it, patients are counseled to use half of that bag. Don't use the whole bag, use half, see what happens, and then use the other half. We also have a huge Narcan prescribing program. We give Narcan out. We actually, every year, so this year, August 31st, we'll have set up on the New Haven Green a pharmacy that dispenses Narcan to the patients in the community. So in addition to the fentanyl trust strips, which are great to give out to patients as a safety measure, make sure that you're also incorporating Narcan in your practice. We want everybody to have Narcan. Even if the patient says, I don't use drugs, we'll always say, well, somebody in your family might use drugs, your neighbor might use drugs. We want everybody to have Narcan within easy reach because Narcan saves lives. Jay is reminding us that we're supposed to stop in 5 minutes. So if anyone has any parting comments, or if there's anything that I said that wasn't clear, if you have any other questions, feel free to email me, robert.bruce@yale.edu. I'm very happy to try to answer anything else or connect you to other resources. Really appreciate everyone's conversation. And most of all, I just want to really give respect to everybody who's willing to take care of drug users with HIV. This is not the most popular group of people to care for. And so it is such a pleasure to talk to you. And it's so encouraging to me to see such a wonderful group of people committed to excellent care for a group that I certainly hold near and dear to my heart, and that's people with HIV and substance use disorders. So thank you all so much for the work that you do on the front lines to care for our patients.